Get ready to be back. First lecture here since I've retired, so that's good. My wife told me smile a lot so that I would be able to encourage all you young people that life is good all the way to the very end. Promise. So, so that is happening. If you can get them back, maybe somebody can help me.
Thank you.
Try both of those.
Yeah, that's it. Now, yeah.
So I do have one disclosure. I am the Chief Medical Officer of Guideway Care. Guideway Care is a spinoff company from work that we did here at UAD. UAD has equity interest in the company. Toward the end of the talk, I'll talk about what that has done. So cancer disparities emerged in the 80s. Now, we didn't have terms like health equity or health inequity when I started practicing. We didn't even know what social determinants of health were. We hadn't named them social determinants. But we did recognize in the 80s that there was a difference in outcomes between whites and African Americans in cancer, particularly breast, colorectal, cervical. Already know. So we had the purge in the 80s. Breast and cervical. We know that it's related to education, income, insurance status, where you live. We didn't know that with absolute certainty in the early 90s, but we suspected that was the case, and then that was confirmed by much research later. This is what I recognized early in my career. So I became a practicing GYN oncologist in 1979, following my fellowship. And if you look at breast cancer mortality in 1979, there was no difference in mortality, whites and Africans. And you see in the 80s, you begin to have a separation in outcomes. This is death rate, mortality. And that continued into the even now, less now. We'll talk about that. Why is that? What happened? Why did you have equal outcomes until the early 80s, mid 80s?
Started screening people.
Right. We developed ways to screen for breast cancer, and we also developed effective therapies for breast cancer. Prior to that time, you couldn't influence outcome because you didn't have anything that would influence outcome. Everybody did equally as bad. And then we developed those discoveries, if you will, to apply differential. Same thing for colorectal. Very remarkable. No difference. Late 70s, and then you began to see the really pretty remarkable shift from both white men, white, black men and women differences. Now, in 1990, I came out of private practice back to the university. I was part of the Comprehensive Cancer Center. I was actually in the prevention and control program, research program. 1992, we saw that difference in outcomes, which is, here we are at 92, pretty significant differences in outcomes. We were here in the Deep South, and many of you probably don't know this, but so we're right in here. In I mean, you know that. What you don't know is in 1990, we were really the only NCI designated comprehensive cancer center in the Deep South. You had to go to North Carolina, Miami, or Texas to find a NCI designated comprehensive cancer center. Now so we made a conscious decision that we would spend a lot of our research effort understanding, mitigating disparities in outcomes between whites and African Americans here in the South. The question was, how the hell were we going to do it? We didn't really know. But over the course of 25 years, building on one program after the other, we were able to develop a comprehensive way to address cancer disparity. And what we settled on was the concept of training lay people to impact the behavior of underserved or compromised okay. So this is 5 things that really encompass 30 years of work. So I'm going to take a few minutes to describe what we did. You heard Holly talk about the Deep South Network Cancer Control, which is first. That was the first funded program that we did. And what we had heard that somewhere in North Carolina, the University of North Carolina had actually recruited and trained a few women called them community health advisors. They went into communities, promoted breast cancer for a small population in North Carolina, and it was effective. And so what we proposed to do to the NCI was to recruit and train mostly African American women, a few men, and a few white women, and a few white men, actually, to serve as community health advisors in the Black Belt of Alabama and the Delta of Mississippi. Everybody knows where the Black Belt is. It's named for the black soil, but it was where a lot of the plantations were in pre-Civil War time. And so it has a large African American population that's a residual from those times. The Delta of Mississippi is in northwest Mississippi between the Yazoo River and the Mississippi River. It's not the Mississippi Delta you think about down in New Orleans. It's actually, and it's a triangular piece of land that also has a large agricultural component. Also has a large African American population. So both areas have a population, 65% African American, 35% below the poverty. So we went into those communities and trained really remarkable, I think, back on 883 people to serve as community health advisors in those 2 regions. And it was really remarkable. See what happened. There was a 17% difference in mammography screening rates between whites and African Americans in those 2 regions, and we eliminated it completely. So today they're equal, eliminated within 3 years. So what the community health advisors were doing is they were setting up programs, going to churches, going to community events, promoting mammography screening, and it was effective. Guess what happens when you screen previously unscreened populations? Cancer. Anybody know? You find cancer. Exactly. So we were finding cancer at a remarkable rate. Then the next problem was, well, you've got an under-resourced individual, rural area with cancer. What can you do to help them get appropriate high quality treatment? So we actually took 24 of the 883 women that we had trained previously to promote screening, and we trained them to serve as navigators for women diagnosed with either breast or cervical cancer out of the program. So their job was to remove the barriers to the person getting to quality tertiary center with an oncologist to be treated. And you can see the results there. There were 1,384 scheduled appointments for either treatment or diagnostic procedures. And they made 1,286, which is remarkable. It's about 94%. Better than me making my own, making it in the dentist. So we were beginning to understand that lay people, when I say lay people, I mean non-nurse, non-social worker. In this case, some college educated, but most less than college. We're making a difference in the population. So in Mississippi Delta, in a county called Sunflower County, the cervical cancer death rates are huge. So we said, what can we do to impact this area? So we actually trained, again, non-nurses, non-social workers, to knock on every door in Sunflower County and find out if there were any females there. Then if there were, they were 30 or older at that point, find out if they'd been screened. So the answer was no. Either never or not in 5 years. We gave them two options. One, we could give them a voucher to go to the public health department, or two, we would give them a HPV to teach them how to do it. And so what actually happened is the self-test had an 88% completion rate. So that is, if a woman said, I want to self-test, she did it and sent it in, and we had a result 88% of the time. But it was pretty convenient. No, she didn't have to get transportation to go to the clinic. Versus only a 40% completion rate if they chose the clinic. So again, a significant difference. Well, we were moving along, doing pretty good, and then in 2000, when we had our Comprehensive Cancer Center site visit from the NCI, which occurs every 5 years, to prove that you're up to snuff in terms of what you're supposed to be doing. We were accruing 11% of African Americans in clinical trials, but the population, African American population, represented 22% of our cancer patients. So we were under accruing. So NCI says you need to match your population. So we stayed with the theme lay people, and we've trained 4 African American to meet each new African American patient coming into the system to talk about the pros and cons of clinical trials, And then they would see their oncologist and their research nurse. If they were eligible for a trial, they would come back to the clinical trial navigator, who would say, okay, Ms. Johnson, you're eligible for this trial. Do you understand, what we're talking about? They would help explain it if they didn't understand it, or send them back to the research. Now let's see what barriers there are to your participating. Is it distance? Is it finances? Insurance? Is it transportation? Is it you have an invalid husband at home we need to take care of while you are way up here doing this? So they would take care of the mess in life, social disparities, or the social determinants. So look what happened. 2 years, 11% to 22%. So again, remarkable outcome for a non-clinical intervention. We even got into the prevention area a little bit. Of course, this is control, this is clinical trials, but here's prevention. So see if we could, if a community health advisor could have some impact in these rural underserved communities. And so we trained again some community health advisors to serve as research assistants in a weight loss program that was administered in the local community. And all weight loss programs are not spectacular. You get some lose weight, some stay, some don't do very well. But our results rival those of the equal of the same type of weight loss programs in academic institutions. Must have been too slow going forward. What I do, just click the screen. Somebody help, who helped me before? Okay. There we go.
This is working.
If I don't talk so long, it's fine. So in 2011, still here. 2011, following the establishment of the Affordable Care Act, an entity was created called the Centers for Medicare Medicaid Innovation, part of the Affordable Care. They put out a request for proposal for any kind of program that would provide the triple aim, which is better health care at lower cost. So we had already done several things. So we had already shown that community health advisors, lay people, could impact prevention, early detection, evaluation, and treatment. We also showed they could help with active treatment. Remember the navigators that got the women with positive cancers too. And we've shown that they would work in clinical trials. And we had also had something called the Integrated Multidisciplinary Cancer Care Program after I became Cancer Center Director. And we had some navigators, non-nurse navigators with that. But we said, boy, this is a perfect opportunity for us to have a program that goes across the entire continuum of care with cancer. If it worked in all of these other places, why wouldn't it work with patients who have cancer, are going through acute care, survivorship, and end of life? Can we improve the outcomes by having a layperson, a navigator, assigned to each one of those patients to get rid, to deal with the social determinants? So we applied for the grant, got it across 12 institutions in the South. It was all part of that. the health system community network, cancer community network. We trained 40 navigators, non-clinical. In this case, we require the college education. So they were going to be, they were going to be at a higher level than just promoting screening. They were going to be dealing with a patient under acute care, survivorship, or end of life related to cancer. So we did require college education. But again, we specifically avoided nurses and social workers. That was the principle behind it. You could take lay people. And of course, they were dealing with treatment, survivorship, and end of life. The results were actually remarkable. Published in JAMA Oncology in 2017, 2016. But when we compared navigated patients, non-navigated match control across the entire 12 hospital system, we had a 29% decrease in ER visits, a 55% decrease in hospitalizations, and a 60% decrease in ICU admissions. And that's what we had hypothesized in the grant. That by having someone taking care of the social determinants of health, addressing, we could make a difference. Is that surprising to anybody? I mean, people come to the hospital, come to UNB, white, black, poor, rich. What kind of treatment do they get within the walls of the hospital? Damn good treatment, right? But equally. Equally. You don't say this person has no insurance, so they're not going to get this. You give everybody equal treatment within the walls of the hospital and the clinic. So why in hell do you have differences in that? It's what happens on the outside. Now, Richard Davis, Ed Barnum, and all us old farts knew empirically that if you had somebody that was under-resourced, they were more likely to bounce back to the ER after surgery than someone who's fully resourced. So that, the poor farmer's wife versus the bank president, which one was more likely to come back? Well, in my day, it didn't really make any damn difference if they came back. Because if they came back, you started billing again, right? So the payment system was amazingly screwed up, fee for service. And so, they was bounced back. So, we started 30 years ago addressing the issue of the social determinants of health. And of course, I go around with the new company. Obviously, we're trying to sell our product. But it is absolutely amazing how much non-attention health systems pay to the social determinants. It's remarkable. But it's typical of any kind of innovation in medicine, slow to be adopted. And we're getting that because something happened really remarkable last month. But I'm going to save it. Yeah. Here's the other thing. Look at this. So Medicare says, well, y'all did your own internal evaluation, although it was good enough for JAMA to publish it. So we're gonna look at this ourselves. So they hired a company out, an institution, University of Chicago, actually, do an independent investigation. And what they did is they took our 10,000 navigated patients in our system and compared it to 10,000 matched controls, MD Anderson, Vanderbilt. So a Southern NCI designated cancer centers. And they looked at the last 180 days of life. How much did Medicare spend in the last 180 days of life? Navigated versus non-navigated match. 8,000 less. Navigated. And what it was, your hospital admissions, your IC admission, early adoption hospice. Because we had trained these 42 people to do something called, to do a program called Respecting Choices, which teaches the layperson how to discuss end-of-life issues with the patient and the family. So they talk about advanced care planning, early, bypassing the physician. By the way, I gave up on physicians 1989. In terms of you training them to do anything. Having to do with anything outside the walls of the hospital. So, you know, forget it. We're going to bypass it. And that's what we did. So, you know, this is where we stood in 2015, 14, after 3 years of the program. Here we were. We had shown that we could use lay people across this entire continuum in a series of published work. And so we went to UAB administration and said, look, we're getting calls from a lot of people wanting to do this lay navigation stuff. Can we deliver that product across the country to multiple entities? And guess what? Typical university. Everybody's got a full-time job. Nobody has any money. And so who's going to do it? You know, who's going to make this happen? And so wisely, I think, UAB decided, you know, if we're going to ramp this up, we've got to have to spend money. Investment, capital, people that are doing it as a full-time job, not as a part-time job. So we did spin off the company, and the company's doing very, very well. So the principle is you have a care guide, a person, again, non-nurse, non-social worker. We have a pretty sophisticated digital valet. That is, we can send digital messages. But we also have significant development of protocols that the lay individual follow related to any kind of thing you can think of that has to do with social. So it tells them what to do first, second, last. And it keeps them in their swim lanes. Keeps them from making clinical decisions. By the way, in our demonstration project, we had 88,000 encounters with those 10,000 patients by lay navigator. And only one time out of 88,000, we think someone went into the clinical decision making. So they do very well in terms of staying in their lanes. We hadn't had any problems with it. So when we did our demonstration project, I would say our technology was 1.0. It was almost, most of it was pen and paper in terms of keeping up with the calls you were making. And now the technology is 5.0. Really, it allows It allows a single lay navigator to manage 250 cancer patients. So they come in and get in front of their computer. It tells them what they need to do first. Red dots, tasks that have to be done that day. Yellow, not so important. Green, task has been done. And they have elaborate, we've developed in 9 years now, elaborate resource library to allow them to take care of the problem. And we, as you might expect, you can extend it not just to cancer, but to any chronic disease, any problem where you, so we branched out. In fact, look at this. This is UAB data on chronic obstructive lung disease, pneumonia. Look at the difference in readmissions. Navigator versus non-navigator. For other chronic disease. So it's not, it's so simple. It's so all teams should look like this now. So you've got an MD, you've got an advanced practitioner, you've got your nurse, you had administrative and clerical personnel. So that's what I dealt with when I was practicing. That's what many of us still deal with in practice. So you don't have this person. This person is in the stack to manage what? Social determinants, non-clinical issues, all the messy stuff in life that leads to the differences in outcome. And are there any maternal and fetal medicine people in here? Gold mine opportunity. As far as I know, there are no publications assigning lay navigators to pregnant women. What causes the difference in fetal and maternal mortality? Social determinants of application. Those social determinants. Gold enough. And I just have a lot of data to show this company doing well. We resolve between the navigator and a clinical nurse 98% of the problems. 82% are solved by the navigator. He or she will have to bump up about 17% to the clinician. You see, there it is. 81-19. Care guide versus clinical staff. And, you know, it's the messy stuff in life is what you think would be. It's no mystery here. We're telling all this about. Again, let me go here. This is an example of cancer standard protocol. So we have a protocol for constipation, clinical trial, for choking, for indigestion, for insurance, weight change, sleep problems. So there are literally protocols where lay navigator can start to address them. And if she can't solve them, she picks it up clinically. So think about it. You know, all across the country, there are lay nurse navigators. How stupid can you be? I mean, nurse navigators can do all of this, but 70% of their work is non-clinical. Can we afford to have a nurse working below her license 70% of the time? Say no. Hard enough to find nurses, right? And this is an example. Still, you know, so this is 120K versus 30K. This is data we've generated out of the company, and you can see that if you low income, you've got many more issues that navigators have to deal with. Same for white and black. And these are the major domains that we work in. So these are the top 10 barriers by domain. So these are the social determinants. They're either practical, financial, family, physical, spiritual, practical. This is where we really live. So stop there, take questions. But I believe that we have demonstrated clearly now 40 years of work that lay people involved in the social determinants solution is a very effective way to deal with it. That's why I was so excited after 35 years that Medicare has actually decided that they're going to pay non-clinical navigation, which they should have. But they've recognized, I think partly because of our demonstration, that they could save money in the long run. For instance, this little 12 hospital system in a 3-year period of time saved them $57 million. So, questions, comments, rebuttal, fussing. Did I smile enough?
Hey, Dr. Partridge, this is Holly. Thank you so much. Can you hear me?
Yeah.
Thank you so much for that. I have a couple questions. Number one, are you hiring? Because I see this model could be applied easily to pelvic floor disorders, which are conditions that don't kill you, but kill your quality of life. And we're trying to roll into rural areas, Black Belt areas now with trials and trying to increase our patients and educate them about seeking care for these disorders. And I think this model of prevention and control and treatment are just amazing. And the work you've done in this area is phenomenal, and thank you.
Wow. Yeah, we are open for business.
Okay. Any other thoughts or questions?
Maryland fetal medicine people in here, we are having discussions at University of Mississippi or maternal and fetal medicine group about starting a program, so they don't get ahead of you if you don't.
A little conflict of interest there, Ed.
Yes, I did it.
Thank you so much for that. That was really inspirational. Help me understand how the lay navigators deal with the practical barriers, right? So a lot of those are financial and resource limited. So what tools and resources did they use to overcome those practical barriers?
You know, each health system has identified some resources that social workers have used, routinely for years. So if we are engaged, we see what resources are already available through the institution, and then we fill in the gaps. So if a lot of the patients are coming from outside, from 150 miles away, don't have a place to stay, we'll call Holiday Inn and say, would you be willing to work with UAB and give us 15 free rooms? So we have time, because it's our full-time job, to identify resources. Think about the poor nurse navigator that's trying to solve the social determinants. 30% of the time she's dealing with clinical issues. It's just really hard for her. We've got people full time to identify resources. Now, can we solve everything? No. But we can usually mitigate it enough that it doesn't impact outcome. That's the key thing. The other thing that's interesting about the lay navigator, me, is they don't have the white coat effect. So nurses and doctors have a white coat effect. And patients and families are a little bit leery of telling them things that they will tell the layperson without the white coat in a second. You know, about lack of resources. You know, a patient would be very leery about telling the doctor, I really can't afford this. Might tell the nurse, definitely wouldn't tell the doctor, but would for sure tell the lay navigator. And that's a clinical problem. So that goes back up to find a new medicine. If the problem is, well, I forgot to get my prescription filled, we do that, or I didn't have a transportation to get my prescription, we'll solve that. And sometimes we find money. To, you know, not sometimes, but often we can find money actually to pay for the prescription. This ain't rocket science. That's what I've said, you know, man, it is not rocket science. It did not take a genius to figure out how to do this. It's so simple. It's amazing. I can't believe it's been so, you know, it's been so difficult to get it going. Yes, sir.
I was obviously, I totally agree. Very inspirational. The original data that you had was obviously throughout the Southeast. It's a national company, and are these outcomes the same on the West Coast and the Northeast as they are in the Southeast, or do we not know that yet?
Yeah, we're pretty much all over the country right now. We've got like 50. And we find the same thing everywhere. And it doesn't make any difference whether you white Appalachian or black Mississippi or Hispanic in Arizona. You're under resourced, you're under resourced.
I think
Dr.
We got a question.
The lay navigators, it makes like a ton of sense, the need that they meet, especially in like the preclinical area, but in spaces where we do already have social workers, how are they like integrated in? Does the social worker like communicate with them, or does they like oversee the lay navigators, or how does that work?
Different hospitals do it different ways. Sometimes a nurse navigator will serve as the overseer of or the person that we would kick the clinical problem up to. Social workers love us because there ain't enough social workers to take care of all the social problems. And so we kick, you know, really complex social stuff. We can kick up to the institutional social work. We take the little stuff off, you know, little transportation. And that's huge. It's huge. We don't have either one of them. Enough of either one. I mean, what I set out to do 30 years ago was to show that you could take, and it went beyond my expectations, but that you could take, because I started out with uneducated community health advisors, just teaching them how to promote breast and cervical cancer. But as it turns out, it makes all the sense in the world and remarkably successful. But that's not surprising. I mean, if somebody's dealing with it, then you got a chance to actually influence outcomes. But there are not enough clinical people in the world to deal with all the social determinants. There are not enough doctors, nurses, or social workers. Period.
How are you guys recruiting the navigators? Are they local to the areas that you're going into, or are they more
We do
remote?
most of it by phone. And so remotely. But each patient has their own care guide now. All that, you know. So every time they call in, it'll roll over to their care guide, unless their care guide's on vacation. Somebody else picks it up. We put them through an industrial psychology profile. We want somebody that's a problem solver. We want somebody that has empathy, but not too much. We find if they're real empathetic, they burn out, they get too involved. Obviously, if they're not empathetic enough, they're ineffective. So we need that sort of medium range person, all college educated, haven't really looked for this work. Not a part of it.
Dr. Partridge, there's a question in the chat from Dr. Waterbore. John, do you want to go ahead and just ask it?
John, hey buddy.
Yes, Ed, I'm Ed Partridge's #1 fan. You might have mentioned this, I missed a little bit of your presentation. Hispanic populations or other populations that, leaving even medical things aside, there are language barriers or difficulty understanding just because they're not very highly educated. And I wonder if you probably thought of this before. Is this easy to overcome? If anything is easy, or is it very difficult?
We have Hispanic speaking guys, care guys.
Oh, great. Okay,
We ramp that up as needed.
great. Okay.
What have been some of the barriers of getting other hospital systems to incorporate some of this into their own system?
So if if you're in a straight fee for service system, you gotta find money somewhere to pay for a care guy. And you really don't get any real benefit. But if you say a bundle, say Medicare is paying you $5,000 to take care of this COPD patient who just got hospitalized for 90 days. But you got to keep her from bouncing. So now, care guy's worth it, right? Because if you can keep them from bouncing back in, you get to keep the residual from the bundle. Medicare did something innovative, I think, as part of our program, at least the program that it is, part of the innovation plan. Because they had something called the Oncology Care Network, or Oncology Care Model. So they would give you $960 per patient on chemotherapy up front, in addition to all the other fee for service. And if you save them money at the end compared to your historic model, they shared that with you. UAB got something like $4 million in bonuses over an 18 month, 24-month period of time. Still using this model. So it depends on the payment. Fee for service is hard to sell. But listen, isn't it amazing? I mean, why should it be hard to sell? Because we're supposed to be worried about outcome. Right? Okay. So we know what causes the differences in outcome. It's not what you guys do in here. Y'all do great. Y'all do great. Comes outside. Makes a difference. Always been the case. Maybe 25 or 30 years ago, there was a difference in quality of care given inside the walls of hospitals. But there's so much, quality improvement, oversight, and so forth, standardization, that's less of a problem than it was 30, 40 years.
Yeah. All right. Have you been, if I was running a hospital system like Kaiser, for instance, that has a pot of money and they're very algorithm based to, whether it's pap smears, mammograms or whatever, but I would rip this off if I was part of that, because of you're basically saving in the pot of money. Do you guys, I mean, this is a sidebar, but do you know if they do it or if someone like that has
No, we've approached them and they had invited us in. It's a harder sale than you would think in fee for service. They would not.
We're on the money topic. Do you find that there are any portions of the cost analysis or specific data that the money people respond to or that are most effective to get people to change their mind that it's worthwhile?
See if I understand your question. So, You know that it's a difficult sell in Petersburg. It's much easier to sell sharing risk. So any program with a shared risk between the payer and the provider, much easier to sell because you're sharing the risk. So if you can reduce the risk, the cost, you get more. That's easy. Easier, but even some of those. It's something about my generation. The only way to fix a healthcare problem was technology or nurse. Every problem that creeps up over the last 50 years when I was practicing, the administrators wanted to fix it by some kind of technological innovation or nurse. Nurse navigator, nurse practitioner, you know, on and on and on. Like, you cannot, under any circumstances, with a non-clinical person, discuss anything having to do with medicine with your patient. Right? Right, Cindy? That's right. Isn't that the way it was? Oh, no. Oh, no. Gave up on doctors a long time ago.
Topic of technology, have you guys looked in, it sounds like a lot of this is like very algorithmic, how you solve problems. Have you looked into like AI to lower your cost?
We have not yet. Good question. I don't think I'm gonna live long enough to probably, but people on the team are young enough and young enough. That's probably something we think.
I'm curious, like, how the lay navigators are compensated, just because you said this isn't rocket science, and like, I think from a resident perspective, at least, a lot of this is like the rocket science that we encounter on a daily basis. Like, the algorithms for obstetric care are in our brain, but to be able to fix the life stuff is what like becomes really important.
Around.
And are they like, they're all mostly studying what, and what are their degrees in? I'm just curious.
They're not social work, they're not.
Right.
Thank y'all, appreciate it.